Hello everyone, this is Ken Stoltzfus. I want to talk today about treatment planning. It's the second step in the clinical psychology treatment process. So once we've assessed the client, then we work with the client to develop a treatment plan. Having a formal plan to follow with our client, it's one of the things that differentiates professional and non-professional helping. And I said this in the first video lecture, but excuse me, one of the things that makes the work of a clinical psychologist different than what happens when a couple friends sit down and talk about their problems is that the clinical psychologist has a plan that they follow. And they've got a treatment process they follow, but they also have this plan that they make up. And that plan needs to be based on theory or research evidence or both whenever possible. So, sometimes a client has something going on that not much research has been done on, that not many theories apply to, but usually there's something that someone else has developed, whether it's a theory or ideally research, that's going to give us some guidance on what we should do. And this process of using research evidence to guide our interventions and our treatment planning, this is what's known as evidence-based practice, or EBP. And there's a couple articles by Stewart and Chambliss and Holland that I asked you to read for this week, and so they give a lot more information about evidence-based practice. But evidence-based practice is so closely tied in with the treatment planning process that I'm going to take most of this lecture to just give you a little bit of an overview of evidence-based practice, how it relates to treatment planning, and then I'm going to end with just a couple slides about the nature of the treatment plan itself. So evidence-based practice started in the 1990s. It's based on the evidence-based medicine model. This model says that when you go to see a doctor, the doctor shouldn't just do what they learned in medical school 20 or 30 years ago, but they should hear what your complaint is, make a diagnosis, and then they should actually either leave the room or on their phone or on a computer in the room. They should look up the diagnosis they've given you, and they should figure out what does the research evidence say is the best treatment for the condition that you have. And so when we take this to clinical psychology, what this means is that we're trying to engage in practice that's informed by the best available research, and we're using what's called ESTs, or empirically supported therapies, whenever possible. When we're trying to identify ESTs, randomized controlled trials, or RCTs, are considered to be the gold standard. Now, so the best sort of research evidence is a randomized controlled trial. You've probably learned about these in other classes, but an RCT is a study that includes random assignment to a control group or a treatment group. It's a similar model that's used for testing new medicines. So if we only have one group in our study and we do cognitive, say we've got a group of depressed people and we do cognitive behavioral therapy and they get better, we don't know whether cognitive behavioral therapy is better than no treatment. Maybe they would have all gotten better with that. Maybe they would have all gotten better without any counseling or any psychological treatment, or whether it's better than some other form of treatment. And so usually what we want to do is we want to compare our intervention to either some other form of treatment or no treatment at all. And comparison with no treatment is good. It lets us know, is there a difference between no treatment and working with a psychologist. But what's even better is to compare alternative treatments and no treatment. Just have a study that has 3 or more groups. So we might have one group that uses cognitive behavioral therapy, another group that uses psychodynamic therapy, and another group that receives no treatment at all. And there we can start to see which one of the treatments are better. Because having 2 different forms of therapy controls for non-specific therapy factors such as attention and the therapeutic relationship. So there's some people that say, well, just the process of sitting down with another human being is healing, and so maybe all therapies are sort of similar. And so we want to see for depression, is one therapy better than the other? And if we're testing 2 different forms of therapy, we know that if people get better with one therapy at a rate that's higher than with the other therapy, we're pretty sure that it's not just these non-specific factors, that what's going on is more than just paying attention, having a therapeutic relationship with somebody, but that therapy itself, that specific type of therapy, is causing some effect. It's important when we're trying to do this to use valid and reliable outcome measures and to be able to replicate the study. And for most clinical psychologists, they're not doing the therapy themselves, or they're not doing the study or the research themselves, but they're looking at whether the research was done well. And so they want to see, was the person that did the research using valid and reliable measures? Has the study been replicated? It's really powerful when the study finds when multiple studies find the same things, especially if those studies are done by different people in different places. A few evidence-based practice terms you might hear. One is number needed to treat. Sometimes this is abbreviated NNT. This is the number of clients who must experience an intervention before one makes significant progress. So the lower the better with the number needed to treat. So if there's a number needed to treat of 2, that means that out of every 2 clients who are treated, 1 gets better. About 50% of the clients make significant progress from this treatment. Because no treatment works for everybody all the time, so that's why we use that number needed to treat. We also want to look at effect size, which I know that you know about from other classes, but effect size looks at the strength of the relationship between the intervention and the client outcomes. Another thing that's really helpful in determining ESTs, empirically supported treatments, is looking at a meta-analysis. This is a study which synthesizes the results of a number of different research studies. And they use statistical procedures to determine the effectiveness of the intervention. And they do that in statistical terms. They figure out the effect size, the overall effect size of the intervention. Some of the interventions with the most support in general in terms of clinical psychology, cognitive and behavioral interventions have received the most empirical support, but other interventions have also received some support. And so the joke sometimes is that what's the empirically supported treatment? Well, it's always CBT, cognitive behavioral therapy. And it's true that that works for a lot of things, but there's also some other things that work too. And so we don't want to disregard those other therapies. APA Division 12, the Society for Clinical Psychology, they have an EST classification system, and they say that an EST is well established or efficacious and specific if there's 2 or more RCTs or a large series of single case experiments that support that EST. We say it's probably efficacious or possibly efficacious if there's 1 RCT or a small number of single case experiments, and we say it's promising if it's supported by less rigorous studies. So obviously promising is worse than well established. Some places to find evidence-based practice information. I've got some websites there, the Campbell collaboration, the Cochrane collaboration. And then also this Society for Clinical Psychology, the APA Division 12, they've got a list of DSM disorders along with evidence-based practice interventions, and you can find that at the link here. And so you can look up the diagnosis, and it'll show you what the ESTs are for each diagnosis. So when we're developing a treatment plan, once we've figured out what the client needs, and we figured out what the diagnosis is and what some of the ESTs are, then we have to make up the treatment plan. And so what we want to do is we want to start with some broad goals. And these goals don't need to be measurable, they can just be general. For instance, it might be that if we were working with a child, we might say that Joey will improve his behavior management in school, that he'll behave appropriately in school would be another way of saying that. So that's a broad goal. We don't have a way to measure that. We don't know when he's behaved appropriately. Does he have to do it for just 1 hour? Does he have to do it all day, all week? What does appropriate behavior entail? Which rules does he have to follow? So then we want to make it more specific. So we break it down into objectives. That Johnny will comply with all classroom rules with no more than 2 infractions per week. Well, we can tell at the end of the week whether he's done that or not. Sometimes we also add tasks to the treatment plans, and those would also be measurable and specific. And so the task there might be, if we were going to use a behavior modification system, the tasks might be that the teacher will set up the behavior modification system, that the parents will review a report of the behavior modification system each day, and that the parents will provide a reward if Johnny receives a certain number of positive marks in the behavior modification system by the end of each week. So those would be specific tasks that need to be done. I will post on the Moodle site, I'll post a sample case study and treatment plan just to give you a better picture of that. Finally, I want to emphasize that treatment planning has to be a collaborative process. There's a tendency among new psychologists to meet with a client and then to sit down and make up the treatment plan by themselves, that's really not a good idea because we want the client to own the plan. We want them to be invested in it. And so we need to make these in partnership with the client. So usually once the assessment's done, the next session I sit down with the client and I say, okay, we talked last time about how depressed you're feeling. What are some things that help you to feel better from depression? Here's some things I think would work. Are you willing to commit to doing some of these things? And we really flesh out that plan. And so we make a goal, we figure out what the objectives are. Sometimes we figure out who's going to do what, and that would be the tasks. But the overall idea here is that the client needs to have at least partial ownership of that treatment plan. Here's some references in case you want to read more about treatment planning and about evidence-based practice. And that's all for this time. So we've talked about treatment planning tonight. Next time we're going to talk about the last 3 stages in the clinical psychology treatment process. That would be intervention, evaluation, and termination. Have a good week. I'll talk to you soon. Bye.